Welcome to the Economist in Your Ear podcast. If you follow American politics, you know the universal fury over drug prices. They're just sky high, often 4 times what comparable wealthy nations pay. Given that justified anger, why is the seemingly simple solution just forcing U.S. drug prices to match the lowest foreign price? Why is that actually seen by many analysts as, well, worse than the disease itself?
That really is the core question, isn't it? The public anger is completely understandable. And the policy you mentioned, the most favored nation, or MFN plan,
Yeah.
well, it sounds straightforward. The idea is branded drugs sold here have to match the lowest price found in, a basket of similar countries.
Right, and the way they plan to enforce this is, well, pretty blunt. The sources talk about using import tariffs on drugs made overseas, almost like a cudgel.
Exactly. That tariff threat is the big stick. But our goal here is to look past that and past the easy, greedy pharma headlines. We need to dig into the complex economics of U.S. drug costs, figure out who's really making the money, and crucially, what kind of, dangerous side effects MFN might trigger globally.
Okay, let's unpack that common narrative first. The usual assumption is high prices mean greedy drug manufacturers. That's where all the political heat is directed. But if MFN only targets those companies, is it even hitting the right target?
Well, the analysis suggests it's largely missing the mark. If you only focus on the manufacturer, you miss probably the biggest piece of the puzzle here, the huge concentration of profits further down the supply chain.
Really? Further down? It sounds pretty significant. Where exactly is this money hiding?
So the analysis we looked at covered about 220 listed healthcare firms. It found that if you define excess profits as, say, anything above a reasonable 10% return on capital, then 3/5 of those excess profits are actually captured mid-supply chain.
Mid-supply chain, you mean?
Hospitals, insurers, distributors, and particularly the pharmacy benefit managers, the PBMs.
Hold on, 3/5. So even if this MFN plan manages to, squeeze the manufacturers and lower their prices, we're still only tackling maybe 2/5 of the excess profit problem based on this data. That's kind of staggering.
It is, and the PBMs are absolutely central here. They're often described as the market's black box. Think about it. The top 3 PBMs process almost 80% of all prescription claims in the U.S. The FTC, the Federal Trade Commission, has actually flagged their practices on rebates and steering patients towards certain drugs because that level of market power lets them shape the market, not just manage benefits. Okay, so it sounds like any reform that's actually going to stick, any successful reform has to deal with the PBMs, the competition issues, the lack of transparency there. But let me play devil's advocate for a second. Doesn't the manufacturer still set the initial list price? If MFN forces that price down globally, wouldn't that give PBMs less room to play games with rebates and maybe force costs down anyway? That's the logical thought, yeah, but it bumps up against the incentive problem. If you don't fix the underlying structure, the opaque system where PBMs often get paid based on a percentage of the list price rebate, they still have an incentive to favor high list price branded drugs, even if a cheaper generic or biosimilar is available. MFN just chases the list price down. It doesn't fix the incentive. It might even encourage more complicated rebate schemes, more opacity, not less.
That really makes the MFN strategy seem like it's missing a huge piece of the structure. Okay, let's talk about the MFN concept itself then. It sounds great on paper, right? Simple, patriotic even. Why shouldn't Americans pay the lowest price available globally? What's the hidden cost that, say, Europe or Japan might be paying for their lower prices? The cost we might accidentally import.
The hidden cost is really about access and innovation. It's fascinating because when you import foreign prices, you're implicitly importing their approach to valuing health, their trade-offs. Europe and Japan generally get those lower prices because they accept certain things, more restricted lists of covered drugs, approving new medicines later than the U.S., and sometimes approving fewer drugs overall.
We hear that argument, but can you put some numbers on it? How big is that access gap, really? How much faster is the U.S. system at getting new treatments out?
It's pretty substantial. The data we reviewed showed that between 2014 and 2022, about 1 in 5 new medicines approved by the FDA here in the U.S. never actually got approved in Europe. 1 in 5. And for the drugs that did get approved everywhere, 2/3 of them got the green light first in America.
2/3.
Yeah. We're talking maybe 6 months ahead of Europe on average, and almost 3 years ahead of Japan.
Wow. Okay, so the U.S. system, partly because it allows for higher potential returns, essentially funds a lot of that cutting-edge, first available treatment globally. And imposing MFN on the U.S., the world's biggest market, would fundamentally cut back the potential reward needed to justify the huge risks of R&D.
Exactly. You have to remember, drug development is incredibly risky. Something like 90% of drugs that enter clinical trials ultimately fail. If you dramatically reduce the potential upside in the single largest market, you inevitably reduce the willingness to take those massive financial risks. That could really stifle future innovation, not just for the U.S., but globally.
Okay, but let's be honest about the price gap, too. We can't just brush aside the fact that branded drugs are 3 or 4 times higher here. That's real pain for people.
Absolutely. Cannot ignore it. But the nuance here is critical for designing smart policy, not blunt ones. While overall U.S. drug spending is maybe 2.5 times higher than peers, that difference is almost entirely driven by branded drugs. They are indeed 3 to 4 times higher. But crucially, the U.S. market for generics, often cheaper than abroad. So a policy like MFN is like using a sledgehammer. It hits everything, including innovation when maybe you need a scalpel to target the specific issue of branded drug prices or those middleman profits.
Right, which leads us neatly into the operational headaches. Even if you agreed with the philosophy of MFN, it sounds incredibly difficult to actually implement cleanly. Why is it seen as so operationally fragile?
The biggest problem is opacity. That lowest foreign price MFN aims for. It's usually not a public list price. It's typically a confidential net price agreed upon after secret rebates between the manufacturer and the foreign government buyer. U.S. officials can't easily see or audit that true net price abroad.
So it's not like you can just look it up online.
Not at all. Which means drug companies can, frankly, game the system pretty easily to protect their U.S. revenue.
Okay, how? How does a company game a system that says match your lowest global price? Paint us a picture of the workaround.
Well, think of it like a bit of a shell game. They have a couple of obvious moves. First, they can just raise the public list price in those foreign countries, while at the same time giving those governments even bigger confidential rebates behind the scenes.
Ah, so the foreign country still pays the same low net price.
Exactly.
Yeah.
But the reported list price, the one MFN might try to reference, looks artificially higher. That protects the U.S. price anchor.
So the price MFN is chasing might be completely bogus?
Could be. And second, and this is really important, companies could just choose to delay launching their drugs in those really low-price countries altogether. Why would you anchor your price in the huge U.S. market to a tiny market that pays almost nothing if you can just wait and launch there later after the U.S. price is set?
Which means the net result of MFN globally might not be lower U.S. prices, but actually slower access for patients in other countries and even more secrecy about prices everywhere.
Precisely. And then there's the whole tariff cudgel issue itself. Just slapping tariffs on imported drugs or their ingredients. That could easily backfire. It might raise costs, create supply chain chaos, fragility, especially if we rely on those imports. And it might not even control the final net price if the PBM deals are still tied to the high list price anyway.
Yeah, it's telling that the administration already seemed to pause the initial tariff start date mentioned in the sources, suggests maybe they saw how tricky it could be in practice.
It certainly suggests a recognition of the operational difficulties.
Okay, so if MFN is, as you say, an attractive message, but ultimately a fragile shortcut, what's the alternative, the perhaps less glamorous but more credible path forward? This seems to be where the idea comes in that America could maybe borrow Europe's approach to figuring out value rather than just trying to import its prices.
Exactly. The more durable path seems to rest on 3 main pillars, really. They focus on value, competition, and protecting patients directly. It's definitely more complex than MFN, but it targets the actual root causes.
Okay, let's take the first pillar. Value negotiation. How do we negotiate drug prices effectively without just slapping on foreign price caps, which we've discussed has downsides?
The focus needs to shift to pricing based on a drug's actual clinical value and its overall budget impact. We stop just accepting whatever list price the manufacturer sets. And the good news is there's already a mechanism starting up. The Medicare Drug Price Negotiation Program, part of the Inflation Reduction Act, is set to establish the first maximum fair prices for a small number of high-cost drugs, taking effect in 2026. That process needs to be strengthened, expanded, and kept focused purely on demonstrated outcome-based value.
Right. Pillar 2, tackling those middlemen, the PBMs, who you said capture 3/5 of the excess profits. We can't just complain about them. What specific actions could actually fix the PBM market mechanics?
We need fundamental changes to their business model. Things like moving towards pass-through PBM models.
Explain that pass-through.
It just means the PBM charges a clear, flat administrative fee for its service, and passes all the rebates and negotiates directly back to the health plan or employer. No hidden margins. We also need to ban spread pricing.
Okay, define that one too, for folks maybe not deep in the weeds. What's spread pricing?
It's basically when the PBM charges the health plan, say $100 for a drug, but only pays the pharmacy $80 for dispensing it, and then just pockets the $20 difference, the spread. It's a major source of hidden profit.
Got it. Opaque.
Very. And critically, we need to delink PBM compensation from list price-based rebates. Take away that financial incentive for them to prefer high list price drugs over cheaper alternatives.
And what about something called rebate walls? That sounds like it fits under this competition pillar too.
Absolutely. A rebate wall is essentially when a big drug manufacturer offers a PBM huge rebates on its blockbuster drug, but only if the PBM agrees not to cover competing lower-cost drugs, like generics or biosimilars, on favorable terms. It effectively blocks competition. We need much tougher action against those kinds of deals to really boost generics and especially biosimilars, which are copies of complex biologic drugs.
Okay, makes sense. And the third pillar, direct help for patients at the pharmacy counter, capping what people actually have to pay out of their own pockets.
Correct. This includes things like capping annual out-of-pocket drug costs, which, again, the Inflation Reduction Act is starting to do for Medicare, and, crucially, requiring insurers to apply the rebates they receive at the point of sale, right when you're at the pharmacy counter.
So my copay would be based on the net price the insurer actually pays, not the inflated list price.
That's the idea. Currently, you often pay your share based on the high list price, even though your insurer gets a big rebate later. That needs to change. Also important here is enforcing site-neutral payments, preventing hospitals from charging way more for administering infused drugs than independent clinics do for the exact same service. That's another source of inflated costs.
Okay, so pulling all this together, the takeaway seems to be that the huge U.S. drug spending issue isn't just about manufacturers' list prices. It's heavily driven by market design flaws, lack of transparency, and these powerful middlemen like PBMs who benefit from the complexity. MFN sounds good politically, maybe, but it looks like an operationally shaky shortcut that could seriously damage U.S. innovation and global access to new medicines.
Right. The more credible path, although definitely less simple to explain, involves negotiating based on real value, fixing the broken PBM market, and directly protecting patients from high costs. That seems more likely to be durable and target the real sources of excess spending without killing the R&D engine.
It really feels like the MFN plan is essentially proposing to import another country's answer to the question, how much is this drug worth? Trading, potentially, future breakthroughs for today's price cuts. Maybe the real question the U.S. needs to grapple with isn't just how low can we force prices, but something more like, how do we design a system that reflects our values, including a strong preference for innovation and early access, while also demanding transparency and ensuring we get real, outcome-based value for the money we spend?
That's precisely the conversation we should be having. How do we want to value health and innovation in the American context?
Thanks for listening. Follow us for daily insights into world affairs, and don't forget to like, comment, and share.